Hello, everybody. That's much better. Hello, my name is Don. And just to say that, actually, is something taken from personalised care, because in the United Kingdom, we had a social movement amongst professionals called Hello, my name is, because the experience of people, particularly in hospital, was professionals would come to them and say, you're the arm, and this is what I think we're going to do for you, without ever introducing themselves. So as a patient, you didn't even know who this person was. So we have this huge movement called Hello, my name is, and my name is Don. I work for an organisation called National Voices, which is in England, not the whole of the UK. The most important thing on my slides is here. That's my Twitter address, @MightyDread. And I'm going to talk a little bit about a brief history of integrated care in England, some of which Tony has touched on. But really my theme is about, are we talking about integrated care, or are we talking about person-centered care? Are those two things that we can keep together, or do they inevitably pull apart? And I think this is a dilemma that we face, having been involved with developing integrated care in England for some 7 years now. This is a constant dilemma. So, National Voices is a civil society organisation. We are an umbrella association for NGOs. We have about 160 members. They all work, the members all work in either health or social care or both. Our mission is to push for person-centered care. And one of the ways we describe that is people having as much control and influence as possible over the decisions that affect their health and care. And we work mainly at the national policy level, so we're a policy-facing organisation, but increasingly also we work with local areas and systems to try and help them make these changes. So, here's our brief history. In 2012, everything in the health system was reorganised through a massive act of Parliament, which was described at the time as being so big that you could see it from space. And almost at the last minute, integrated care was put in as a duty for all health organisations at all different levels. And it became a strategic priority for the national government. But they weren't sure what to do. So in 2013, a national agreement was formed called the Shared Commitment. And what they did was to adopt a single definition. So earlier speakers have talked about the importance of everybody having their own perspective, all perspectives being legitimate, was what Tony said, but actually to work together, we all need a common definition. I'm going to talk about this again in a minute. And 25 local areas were given special pioneer status and told they could go and explore integrated care in their own way, discover what the challenges were, what the success factors were on behalf of everybody else, and they would have some extra money to do that. By 2015, the leadership of the NHS in England had already decided it wanted to move to a slightly different model to that. So after only 2 years of the pioneers being at work, in came these things called vanguards. The difference was the pioneers had wide permission to do things their own way in very different geographic areas. So one was northwest London that Tony mentioned, but another one was Portsmouth, which is just a small coastal city. So there was a whole range, and they were doing very different things and starting in different places with different populations. And so the government and the NHS leaders said, that's making it really hard for us to evaluate. the job of the vanguards was actually to describe new care models which could then be taken and done elsewhere, so prototypes, essentially. And now we come to 2019, and in January, the NHS in England published a new plan, the long-term plan, looking 10 years ahead, with a new funding agreement with government. And that sees integrated care happening in every area, not just in pilot areas. And one of the key factors in delivering that is going to be a new setup for primary and community care called primary care networks. Now, there is continuity in here. These things aren't clear breaks, because if you were doing integrated care really well in 2012 already, you probably became a pioneer. And having been a pioneer, had some more money, done some more work, you probably became a vanguard. And having been a vanguard, you're probably in a good place to do all the things in the long-term plan. So for those areas that have got strong relationships and have come on a journey of building trust, there is some continuity. So I talked about a single definition. One of the people who helped us very much with this was a lady called Barbara Poynton. And she is the Barbara of Malcolm and Barbara in Tony's slide. So she was the carer for 16 years for her husband, who had Alzheimer's. One of the things Barbara said that I never forget is, what's primary care and what's this secondary care? What's tertiary care and social care? She said, from my point of view, care is care is care. You're the people who call it different things. So with that message in our ears, we tried to define what integrated care is from the point of view of people who need to use the services. And the first thing we found is that nobody's interested in integration. Integration is a word that means what you do to join things up. Okay? I don't want to know what the electrical wiring is like in my house, but I do want an electrician to come quickly if there's a problem and help me fix it. So people are not interested in integration, but they are interested in coordination, because that means things working together in their interests. So we defined it as person-centered, coordinated care. So we put the two things together. And in each of these boxes, which are about things like information, communication, decision-making, is a set of statements that say what that feels like from my point of view. So they became known as the I statements. But the summary of all those statements is that I can plan my care. So this is for people with continuing conditions of various kinds. How does it make sense that they should keep coming back to the system for short, episodic, reactive consultations that fix one problem at a time? If you contract asthma or heart disease in the middle of your life and you're still going to live for another 40 years, why can't you plan the way your life is going to be as a person with asthma or heart disease? And why can't you do that with all these very clever, very professional, very caring people who are grouped around you? So the statement is, I can plan my care with people who work together to understand me and my carers, allow me control, there's that word again, and then bring together what's important to me. So that was adopted in a national declaration that the government, the health system, the local authority social care system, the care regulators all signed up to in 2013. Here are some of the statements that I just picked out as illustrations of some of the key things people said were important to them. So first, that it should be about my goals and outcomes, not about yours. So I am supported to understand my choices and to set and achieve my goals. And taken together, if you take every little bit that makes up the jigsaw of my care and support help me live the life I want to the best of my ability. So that's one of my themes. This is about people's lives. As the child's map of care that Tony showed demonstrates, the health part is only one part of people's lives. And as his diagram about self-care showed, most of the time, most of the decisions that I take about how to cope with my health conditions, I take in my own environment with my own support system, if I have one. Care planning I've mentioned, so I work with my team to agree a care and support plan. This is not a care plan as doctors often, or other clinicians often consider it, which is the plan I make for you, because I'm an expert in your condition. This is the plan that I make for myself with your support to meet my goals. And that's clearly on my record, so everybody knows, assuming we can share records, which you can do here, but we can't yet. We're working on it. And care coordination, not the 12 touch points, but I always know who is coordinating my care, and I have one first point of contact, and that's someone who understands both me and my conditions. So Barbara Poynton, again, to quote her, said, "The person I am looking for is the person who will walk beside me with the backpack of knowledge." So they know me, they know my carers, they know what happens in my life, they know the impact of something changing in my life, like the loss of a carer. But they also know what it is, in health terms, will help me to support myself. Now, last year, our Parliamentary Health Committee, which is independent, is cross-party and independent of government. By the way, we don't have a government anymore. I lost my Prime Minister on the way to the conference. She resigned this morning. As you can see, the English are really well qualified to come and tell you about how to organise things. Last year, our Parliamentary Health Committee had an inquiry to which we and others gave evidence to look at how far we'd come since 2013. And they said, basically, you lost your way as a health system. Through that period of change from one model to another, from one idea to another, you lost your way. You put too much focus on organizations and structures. And that's resulted in nobody really knowing what's happening anymore. Poor communication. Acronym spaghetti, I don't know if you can translate that, but it means, all the focus being on things called ICS or STP or PCN or whatever. And even people working in the system don't understand that because it all comes from a policy stratosphere. And in fact, what they said was, you need a new common narrative. And what we said was, we made one of those and everybody agreed it, so let's get back to it. But what they're saying is, don't forget that anything you do should be about achieving more coordinated, person-centered, and holistic care for people using the services. So, now we have a new plan. This is the long-term plan for the NHS. The NHS took the leadership of this because government wasn't leading on anything. Government agreed to sign over some extra money, so we have more money coming into the system. And at the top of the plan is this idea of a new service model where, for the first time for many, many years, growth in the system is going to be at primary and community care level, if all works. So more money, new types of contract, different kind of activity happening in primary care and community care. This will be done by the primary care networks, which I'll describe in a moment. Last week was the deadline for every area of England to apply, for the organisations to apply to work together as a primary care network, and by July, those will all be agreed. There are ambitions to reduce emergency department usage and outpatients significantly, trying to cut the use of outpatients by a third because it rises all the time. More digital-first access. There's a lot of enthusiasm for digitization at the moment. And as Tony was talking about, a population health management approach within things called integrated care systems in each region. So we don't have much devolved power, but we're going to have these systems set up in each region. They will have some permission to take responsibility. The idea of the primary care network is we have small general practices, sometimes with 6,000 or 7,000 registered patients. So the idea is we're going to start moving more to scale and more to collaboration. That the primary care network, which has a special contract and extra money, will join a group of primary care practices with their local community health team, district nurses and so on, with the adult social care team, which is run by the municipality or the local authority, and with the mental health services. And we're told that the voluntary and community sector will also have a stake in this. So this is at very local frontline level, and there is already funding going in to expand the workforce and bring new roles into general practice. We're seeing practices employ more pharmacists directly, paramedics, physiotherapists, and so on. Now, within that new service model, we have another big plan. This one's called Universal Personalised Care. This results from the build-up over the last 8 years, particularly, of evidence, argument, and case studies demonstrating that interventions to support people to take more control of their health and care can be effective. And so part of this new service model is called the comprehensive model of personalization. Again, this is something that we're going to take out of the arena of small pilots and try and do in every area over the next 10 years. And the primary care networks are the ones supposed to deliver it. Now, I've tried to simplify the NHS's slides for this. I think the important thing is that a lot of work on integrated care, particularly for older and complex and frail people, has focused on the top end of the population pyramid, the 2% or 3%, often defined by their cost to the system, their risk of using emergency services, or their degree of frailty. The idea of this model is it takes the top 30% of the population, which is everybody who's got long-term physical or mental health conditions, and it tries to supply proven interventions with an evidence base that will empower those people and help them build knowledge, skills, and confidence to live well with their conditions. So that's the idea of self-management or supported self-management. So some of those interventions are things like the care planning approach, support for self-management, which might include self-management education courses, use of peer support groups, maybe health coaching interventions if someone struggles to make change, possibly the use of personal budgets, which is an exploratory scheme that is expanding, where people are given a part of their health budget to buy in and organize their own care in a way that works for them. That's just a slide that puts all of that technical stuff in simple language. I'll move on quickly. So if you remember my slide about the primary care networks, we can start to look at this in a slightly different way now in terms of someone's personal journey. That they're registered with general practice, it remains their gateway to all other services. General practice has expanded with new roles. It's also the place for making shared decisions, not just for making referrals or for giving prescriptions out. Okay? A key part of this is to have a care and support planning conversation. That's the conversation that changes the nature of the transaction from what's the matter with you to what matters to you. So this is a goal-setting, self-identification process. And it's a cycle. It doesn't happen once. It's a cycle, usually annually. You can then, in terms of how do you support the achievement of those goals, you will be able to access those other services that we talked about integrating with, but there will also be funding to pay and employ a link worker for every one of these networks, and the link worker is probably a non-professional person, probably a community activist of some kind. And their role is to help with the care coordination and particularly to help you access things that might support your health and well-being that are not found in the medical model alone and are not found in the array of professionals to which you now have access, but are found in the community sector. So those things about supporting self-management may very well be out here in the community. And they may well be things that communities are doing that don't have health written at the top of them, but that are about kinds of activities. It might be a walking group, for instance. It might be an arts group. I met someone who made the big changes in his life after years of having a severe mental health condition by going out rock climbing with a group that was attached to a community group working with his mental health trust. Having this focus really on what supports self-management, what supports people to take control, to have the ability to manage their lives and manage their lives in the context of their health conditions, is one of the few things that has been found to work. Most evaluations of integrated care, at least the ones we've seen in our context, tend to find it's a bit more expensive, which is not a popular message with politicians and managers. It's a bit more expensive because actually you're working better with people. You're finding out more about them, so you discover unmet needs and you do something about it. And often it increases hospital use rather than decreasing it. There was an analysis, though, by one of our independent think tanks looking at people in relation to their, what is called patient activation. That's the knowledge, skills, and confidence to manage. They looked at 9,000 people's records who had had an activation score, so you could correlate them. And they found that the most activated, that's the most health literate, the people most in control of decisions about their health and care, had 38% fewer emergency admissions to hospital, and in fact 32% fewer attendances at the emergency department, and also used 18% less in relation to consultations in primary care. And if they were people with mental health conditions, they had half as many emergency admissions as people with the lowest ability to make decisions. So Health Foundation calculated that just taking the least able, the least activated people, those who struggle most with their conditions, and getting them one step up the activation ladder could prevent 500,000 emergency department attendances and 330,000 admissions. So that hopefully I can come back a little when we have the discussion to answer your questions about lessons out of all of this. But I think one of the lessons, one of the things to think about going forwards is how, when we make a process of change, how do we make sure it is cultural change that changes the model of care for the person rather than just creating a better grouping of jigsaw pieces closer to where the person is. Thanks very much.